All right, so we're ready to basically wrap up ethics now. We talked about everything that was pretty much relevant for CK, and as I've told a lot of my step one students too, like all of this stuff is gonna pop up in step one also. So none of this is like unique strictly to CK. It's all pretty relevant, you know. So let's take a look at this now. Last two things that we just need to lightly touch on are conflict of interest and malpractice, and then I'm going to dive right into a bunch of about 2 pages of practice questions relevant to everything we looked at. As far as conflict of interest is concerned, we did talk about this a little bit in an earlier video where I mentioned that conflict of interest is a big problem, especially when it comes to clinical research. Right now, there can be many forms of conflict of interest, but let's take a look at some ideas and some concepts I've personally ran into. So when I was doing my clinical research position in the beginning, I had to sign a lot of documents saying that I'm not affiliated with most of the big pharmaceutical companies in America. And eventually I started buying stocks, especially near when coronavirus started picking up a lot. And when I bought certain stocks of pharmaceutical companies, I could no longer be a part of their clinical trials in my work area. So someone else would have to take up their clinical trials because I actually have a conflict of interest, right? In a sense, it can be argued that if I own stocks of a company A and this company now comes to my hospital to do clinical trials on a certain drug, I might be in in some state of mind where I'd like to kind of make that clinical trial successful, right? That if this clinical trial goes very, very well, the company whose stocks I own will start doing better and then I'll make more money in a sense, right? So that kind of conflict of interest is always going to be a big issue. Now, conflict of interest can pop up in many ways. The stock thing they actually give an example of here, and it's because this is actually very real, right? This is exactly what happens, and it happened with me as well. Right, so here they say a physician may own a stock in a pharmaceutical company that produces a drug he is prescribing to his patient. Right, so there's a different level of that. So maybe if I own a stock of regadenoson, right, this is uh, gonna be a problem, right? If I own the stock of a company that makes certain medications and then I'm in some form entitled to kind of give that medication to all my patients, that's not okay, right? That's not how prescribing medications works. There can be other forms of conflict of interest too. So maybe you have a personal connection to a certain patient, or maybe you have some kind of like personal enmity with a certain patient. Maybe you really feel like one of the other things that happen is this cash thing, right? A physician should never accept cash. So the whole concept of what gifts you should take. Now, you might not have a conflict of interest with the patient, but then you can kind of establish one if you accept certain gifts. You might also not have a conflict of interest with a certain clinical study group, but then you can establish it because of the gifts you took. So what gifts can you not take is a huge deal, and we're going to see some of that in the practice questions I'm going to do at the end of this video. So cash is one issue. You should never take cash from any patient, no matter what. The other thing is that pharmaceutical companies can bring you all kinds of things, right? So if a company, let's say I'm a full-fledged doctor working at a certain hospital, and a pharmaceutical company wants to bring me some new medication for heart failure, right? Give it to all your patients who have heart failure. I'm going to look at the medication. I'm going to see the studies they show me. I'm going to try to evaluate the confidence interval of things, all the data they're providing, check for biases, right? That's okay. Then I'm going to start giving that medication to certain patients who I truly believe will benefit from it. But if they want to give me something, these pharmaceutical companies want to give me something, the only things I can accept are things I would give to my patients, not things I'm going to take home with me. So if the pharmaceutical company wants to give me a bunch of samples of the medication, that's perfectly fine. I'll take all the samples of the medication they want to give me, because those samples are not something I'm going to eat or take home with me. Those samples are what I'm going to give to my patients who might be interested in trying the medication out. If they want to give me booklets that tell me about the medication, that's great too, because I can hand those booklets to my patients and they can learn more about the medication, who it helped, and whatever else data that might be in it. But if this company, pharmaceutical company, wants to give me a laptop for my time, wants to give me some kind of a pen drive, I think is going to be one of the things in one of the questions, things that I can use and take home, that's not okay, right? Because now I essentially accepted cash from a pharmaceutical company, and now I have some kind of commitment to them, right? I owe them in a sense, ethically or unconsciously even, for what they gave me personally. So that's not okay. Don't do that, right? Same thing with patients. If you help the patient, that's great. And patients will often feel like, oh, I owe you for your help. You know, you might go above and beyond for some patient, and they might want to give you certain things. Now, there was a step one question where some family came back to the doctor and gave him cash, no, actually, they didn't give him cash. Remember, accepting cash is not just about accepting dollar bills or something. You can accept other things that have cash value to them. And in that question, I think they gave him like 2 tickets to a baseball game or something. And these tickets in America to watch a baseball game can be pretty expensive. They can go to over $200 to $300, sometimes even over thousands of dollars, depending on how big the game might be, what teams are playing, how many tickets are sold out. Qasim is saying there is no free lunch. Now, free lunch is definitely necessary, so that part should be there, right? If a pharmaceutical company wants to come in and take my time to tell me about the medication they made and all the different clinical trials they've been running and how successful the medication has been, they better bring some food, not just for me, but also all the students that are with me and anyone else that might be part of the staff. So as a student, I have been a part of many of these lunches where some pharmaceutical company came in to talk to the attending I was working under, and they would bring like food for everyone. So it was like a wonderful time for me. I'm gonna say that is someone giving you something for free. There is always a catch. Yeah, no, I agree with you. But the lunch part is like an immediate exchange right there, where they gave you lunch because you could give them time. So that exchange is done right there. Right, that exchange is finished. You no longer owe them anything for the lunch they gave you. So that part is actually okay. This is why I always like calling conflict of interest as something you can take home. Never accept anything that you can take home with you. It's a pretty good way to go, right? So if you take baseball tickets, if you take a laptop from the company, if you take anything that you can, maybe a mouse or a pen drive, anything weird that you can take home with you and has some actual monetary value, like you can actually take it home with you and you could sell it to someone else, you probably don't want to take that. It's, in fact, you definitely don't want to take that. You probably do want to take it, but you definitely shouldn't take it. And you are ethically against, it's ethically illegal in a sense to take it, so don't do it, right? So you don't take anything except for things you can give to your patients, okay? And in that question I was mentioning, the baseball tickets, they also had a drawing that the daughter had made for the doctor, and something else, I forget what else there was, but he could take the drawing because the drawing had no monetary value. It was more of an emotional value. And he could not take the baseball tickets because that has monetary value to it. He can take it home and he can list it on eBay or some other website to sell the ticket to another group that might want to go to the baseball game. So very important to watch out for that. So that's basically all conflict of interest is. If you have a conflict of interest, make sure everyone knows about it. And if you don't have a conflict of interest, make sure you don't establish one by doing something that could lead to a conflict of interest. This page about malpractice, now malpractice, is much more significant than this little section right here. The essential elements of a civil suit under negligence include the 4 Ds. The physician has a duty to the patient. Dereliction of duty occurs. There is damage to the patient, and then dereliction is the direct cause of damage. So what is dereliction? Let me just Google this real quick so I can have this explained perfectly. I mean, I know what it is, but it's one of those things I can't describe. The state of having been abandoned and become dilapidated. Wow, when they use a bigger word or not a bigger word, but a huge word in the definition of another word. But basically, it's the failure to fulfill one's obligation, right? So now, that should never happen, right? So the core of malpractice is basically this term right here, dereliction or dereliction, the failure to do what you were supposed to do, basically. And this happens every day, right? We all fail to do something we were supposed to do every single day. Most students that are studying often fail to study correctly, and we are always doing this act of dereliction with ourselves, where we fail to give ourselves what we were supposed to. So that's why this mentality of, a doctor should look very well kempt, fit, doesn't smoke cigarettes, all these things, it comes from, because if you're going to be out there doing great things for other people, you better be doing great things for yourself first, right? This is harder than it sounds because I don't want to make the patients feel like I don't appreciate the gift or that I don't appreciate them, but it is what it is. Have to be responsible and respectful. Yeah, definitely. The terminology of how you reject a gift is very critical, right? You cannot just rudely reject a gift. So it's very safe to just say, I really, of course, really appreciate your time and the value you place in me, and I'm very grateful for your support. I'll gladly take X, Y, and Z, which are the non-monetary value things, but I cannot take something that has monetary value because it's just simply against my job. But once again, like, I'm really grateful to you for that, and you have to make sure that you start and end with the part that you're saying you're really, really grateful. When you show how grateful you are, the gift's job has already been done without even taking the gift, right? So you basically have to act as happy as you would be if you took the monetary gift, but without taking the monetary gift, so that gratification of giving a gift can be received by the person that was trying to give it to you, right? When you give somebody an expensive gift, there's a gratification to be had, right? When you give somebody a very expensive gift, you feel great seeing them smile, seeing them happy, seeing them try out the gift, whether it's a shared expensive glasses or baseball tickets, whatever it might be. So that happiness is all you really need to see. So as a physician who's rejecting a very expensive gift, you still want to show the same happiness you would have shown if you had accepted it. That often helps not make the patient feel like you're being rude by rejecting a very expensive gift, right? So that's a good way to do that. Now, dereliction. Stop doing this with yourself first, and then it'll definitely make this a lot easier to not do with the patient, right? So this is why oftentimes doctors who are very unkempt, have a heavy smoking history, possibly obese, all kinds of mixes of things. Now, just being an obese doctor alone is not a bad thing. That's not that problematic. But it does make it a little more difficult to go tell your patient, right? You need to watch for your weight, lose weight, etc., these kinds of things. So dereliction often occurs the most, from what I've seen at least. This isn't a statistical background or anything. I don't have any data to prove this, but from what I've seen, is usually the students and the doctors that are disregarding their own health and well-being that end up often disregarding what they were supposed to do with the patient as well, right? So you do not want to fail in fulfilling the duty that you were supposed to, right? Fulfill your own obligations, be responsible. That's basically all that is. When you stop fulfilling your obligations, stop being responsible, dereliction is bound to happen. Unlike a criminal suit in which the burden of proof is beyond a reasonable doubt, right? And these are terminology you would use in court. The burden of proof in malpractice suit is a preponderance of the evidence. Physicians may refuse inappropriate requests, such as demanding to be seen after hours. Even other, there are many inappropriate requests you can refuse. So this is one, right? Demanding to be seen after hours. So like, if your clinic closes at 5 and you were going to see your last patient at 4:30 and 30-minute interview with that patient and then you're done, and someone shows up at 5:05, right? 5:05 p.m., 5 minutes after closing time, and they're like, oh, I need you to see me right now, I don't feel good. You don't need to see them. In fact, you shouldn't see them, right? Because this is where you can establish a conflict of interest as well. If you see them, then you're being unfair to all the other people that might have wanted to see you at 5:10 p.m., 5:15 p.m., 6 p.m., etc. You would tell that patient based off of, so first things first, you will know how bad the patient is by looking at them, right? Are they dying? Because if they're dying, they should probably just go to the emergency at a local hospital, right? If they're not that bad and they can make it one more day, you tell them to go home and make an appointment and come see you whenever next possible. If you want to see them tomorrow, you can. It's your business. A clinic is your business. You can see them tomorrow when you start clinic, right? They can be your first patient of the day, even though there might be another appointment there. You could see him, but you don't have to see anyone after your work hours, right? You're the boss of yourself. You don't have to. And if you do want to, you could theoretically, but you got to be careful not to. You could theoretically see him after work hours, but you have to be careful not to be unfair in a sense, right? It's very hard, this whole value of treating everyone equitably, not equally, as we talked about yesterday. This can also be something that can be a problematic thing, right? Another inappropriate request could also often be romantic requests, right? So a female patient or a male patient or any gender patient, really, any patient that's romantically attracted to the physician might want to request a meeting for like dinner or something, right? Going on a date, essentially. You can easily and full-heartedly just, refuse this and let them know. The number one method most people employ is letting them know they're married, right? Or letting them know they have a fiance. It's so easy to do that, right? So if you have a patient, so for me, example, if a female patient was romantically attracted to me, wanted to meet me after hours or get my phone number or any of these other things, I would easily just tell her that I have a girlfriend, and then that would hopefully end that. After knowing I have a girlfriend, if she still employs certain characteristics with me and tries to get me to come see her in something, then I can just go ahead and do this other thing that's right here in the key fact, which is to end the doctor-patient relationship, right? So physicians are not obligated, right? There are many things we are not obligated to do, but patients do often think we are obligated to do, right? Physicians are not obligated to accept everyone coming to them as a patient. I don't have to take everyone as my patient. Furthermore, physicians also have the right to end a doctor-patient relationship, but just like kicking a tenant out of the house, you have to give them time to find another resource, right? So let the patient know, hey, this is going to be our last appointment together. I'm going to need you to find another doctor for reasons X, Y, and Z. And you be very obvious, very straightforward about the reasons too. Maybe you can't handle their problem anymore. Maybe you feel you're not good enough to take care of their problems because it might be very intricate. Maybe they need a specialist. Whatever it might be, you let them know and then let them find who they need. If they don't know who to find, you give them resources, right? So one of the hardest things about finding a doctor in America is that not all doctors might accept your insurance. Not all doctors might be a specialist at what you practice. So you have to tell them who is, right? And as a doctor, I would know who else accepts my insurance or who else accepts the problems that this patient has, stuff like that, right? But we're not obligated to take everyone as a patient. We're not obligated to help somebody after closing time. We're not obligated to do pretty much many things, actually, right? Many things that many people of different communities do assume is an obligation, right? We're also not obligated to prescribe everything the patient needs, right? So very important to make sure you understand what you do need to do and how to do it, all right? This is all a business. You're a businessman once you're a doctor. Your own clinic is your private business, and when you work at a hospital, you're working for another big industry business, right? So every patient is your client, right? You have to treat them like a client. You have to accept their anger. You have to accept their issues, okay? And you have to respect their confidentiality. You don't tell anyone what business you did with them. No one needs to know, right? So very important to make sure you really get that mentality on. If the patient has a non-urgent condition, the physician should not recommend that the patient visit the emergency department, right? And this is the example I was giving. So I think there was a question, it might be here somewhere as well, but there's a patient that comes in with flu-like symptoms. Now, this question is definitely pre-COVID. So, if a patient comes in with flu-like symptoms and he's like, I need you to see me right now, I have a runny nose, I don't feel good, but it's past your closing time and you were ready to go home, you simply tell the patient to make an appointment, come back later. You don't tell the patient to go to emergency, but if the patient is doing really, 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 really bad, you just tell them go to the emergency department, right? Because that's the obvious thing. Even if your clinic was open, it was under closing time, like you're still working, you wouldn't see a patient that's doing very bad because they probably should be in the emergency department. So that would be the right advice to give. Right, so be very careful in picking the correct answer choice, because oftentimes not knowing these little things can make the correct answer foggy, right? And then you're stuck between two things. So let's take a look at these practice questions now and dive into what's happening and really seal the deal with everything we've talked about, all right? So first question here, a senior resident attends a medical conference at which a table sponsored by a drug company offers free flash drives for all the attendees. So this is one of the examples I was talking about. The resident needs a new flash drive for presentations and asks a friend whether it is appropriate to take one. The friend responds, I think it's okay. It's not an expensive item and it won't affect how you prescribe. According to professional ethic guidelines, what is the most appropriate course of action? Well, see, it was theoretically, in my opinion, it was actually to some extent okay until he said he needed the flash drive. Now It's got more value to it than even the monetary value. But all in all, even if you did not need the flash drive, it would be wrong to accept a gift, as I said before, if you could take it home and if you could resell it, right? So this flash drive is something you can take home. You could also sell it, right? This other physician, this other friend over here can take the flash drive home and sell it to his senior resident guy here that needs the flash drive and sell it to him at half the price, right? So you can see how everyone has something to gain here. And at the same time, because you took this free flash drive, every time you use it, so let's look at the explanation, you can see it. Every time you use that flash drive, you're going to see in your mentality subconsciously that you kind of owe that pharmaceutical company for giving you this flash drive that you so desperately needed. Right? So do not take the flash drive, as only small gifts that directly benefit the patients are acceptable. 25% of people got the correct answer. 75% of people got this question wrong. 30% people chose do not take the flash drive as it is unethical to accept any gifts from pharmaceutical companies. That was a trick answer choice that also looks correct, but that's not true. It is not unethical to accept any gifts from a pharmaceutical company. You can accept gifts. Oftentimes, a tricky answer choice will be accepting a gift, but like I said, it has to be something you could take home or you could resell, right? Those are the things you cannot accept. So there can be a gift you can accept that can have monetary value to it. It's something that you would keep in the clinic and possibly be a symbol of the medication, right? So oftentimes pharmaceutical companies might bring like a teddy bear that might say the name of the medication on the teddy bear, right? That, although it of course has some level of monetary value to it, of course it is something you might be able to resell, but it's not really the equivalent of a flash drive. So something like that is really just a promotional tool. You can leave it there, right? Those things you would take, you would leave it in the clinic area, and when a patient comes in and sees it, that advertisement will help, exactly, advertising, right? That advertisement will encourage patients to ask you about it. But you are still not biased by taking the teddy bear to give that medication, right? So a patient might see the advertisement, they might be like, hey, I saw that teddy bear outside, it was advertising this medication X, Y, and Z. Is it good for me? And then as a good physician, you'll tell them, oh yeah, that is a great medication, but if it's not good for you, it's better for someone like whatever other quality, right? Or maybe, yes, that medication actually is perfect for you. Let's talk about it, right? And then you would go from there. So something like that you can also accept, right? It's always wrong to accept something you can take home or resell. Okay, so very important to watch out for that. Physicians should exercise caution when accepting gifts from external parties such as pharmaceutical and medical device companies that have a direct interest in medical practice. These gifts can influence a physician's prescriptions or practices, even on a subconscious level. To safeguard patients and preserve the reputation of doctors, the American Medical Association guidelines suggest accepting non-monetary gifts from interested parties only if the gift directly benefits patient care and are of small monetary value, right? So unbiased educational materials, drug samples, whatever it might be, right? Things that you can give to the patient. So that advertising teddy bear is also something you're basically giving to a patient, right? You're giving the patient an advertisement, but in no way by giving this advertisement does it make me want to make the prescription for that medication, right? Because I have nothing to gain here. But I would have a lot to gain here if I was maybe in some way associated with that medication, and that every time that medication was sold, I made money, right? That would be like buying stocks. So that's the issue right there. No gifts of cash or high value or with implied reciprocity should be accepted. This implied reciprocity is a very important thing to watch out for, right? I did something for you. Now you know unconsciously that you have to do something for me. That should never exist, right? That's a conflict of interest kind of thing there. The flash drive may be cheap, but it does not directly benefit patient care and should not be accepted. Okay. Next thing, 31-year-old woman, G2P1, is brought to the emergency department by her husband due to heavy vaginal bleeding. She is at 30 weeks gestation by a last menstrual period and has not received prenatal care. She has had heavy vaginal bleeding for the past 2 hours, soaking through a pad every 30 minutes. Her last pregnancy ended in an uncomplicated term vaginal delivery at home. Vital signs and fetal heart rate tracing are normal. A transvaginal ultrasound reveals a complete placenta previa. Okay, so this is a problem, right? This is a gynecological problem. After conservative management, the vaginal bleeding stops. The findings the findings and management, including a cesarean delivery, are discussed with the patient and her husband. She says she does not want a cesarean delivery because she would like to deliver at home again. What is the most appropriate response? Okay, so whatever the answer might be, by this point you should already know what you would do with such a patient, right? Placenta previa is something you would have to understand. If you don't know what a placenta previa is, then you wouldn't know what to do with the patient. 40% of the people, so everyone was divided half and half. 40% of the people chose, I only recommend cesarean delivery because vaginal delivery puts you and your baby's lives at risk. That is the perfect response to give, right? I understand that you want to do a natural delivery at home again. I totally get that. That's okay. And I can see it clearly worked great for you the first time you did it, right? That's why she's already had a delivery before. But right now with the placenta previa and this heavy vaginal bleeding she's had, it is very important to let her know that her baby's life is at risk. Like, she might not care so much about her own life, but she might really care more about the baby's life, or vice versa. Maybe she cares a lot about her own life and not the baby so much. So you have to make sure you mention both things, right? It puts you and your baby's lives at risk. 45% of people chose the wrong answer, which also must have seemed perfect to them. It says, let's discuss the risks and benefits of both vaginal and cesarean delivery again, and then make a decision between the two. I can 100,000,000% see why someone might have thought that was the correct answer, right? But this is not what's necessary anymore. Look, they already had the discussion, right? They told you that the findings and management, including a cesarean delivery, are discussed with the patient and her husband, right? So that means that they discussed obviously vaginal delivery and cesarean delivery, and why all of this is necessary as part of management. It's already been discussed. On top of that, discussing the risks and benefits of vaginal versus cesarean delivery doesn't tell her why this matters for her, right? Her own problem is the placenta previa, and the most important thing to tell her is that that placenta previa issue, if not done, if this delivery isn't managed in the hospital, that placenta previa issue can lead to the death of her and her baby, right? That is very important. After that, we might actually still continue and discuss vaginal versus cesarean delivery. Who knows? There's many other things to talk about, right? But the most important thing and the most accurate response to give, which is becoming a new and upcoming thing for USMLE, they love asking about these things, right? You would have to listen to, you would have to tell them about that, the correct answer. That's the most appropriate response, okay? We have to do what's best for the baby. Not necessarily. So in pregnancy, and I think we talked about this in one of the earlier videos right here in ethics, when it comes to pregnancy, everything is about the mom. Everything is about the mom. If the mom wants X, Y, and Z, she gets that. The baby does not exist as a human being. Right, so this is a very intricate and problematic conversation between many different groups, right? Abortion versus not abortion, pro-choice versus the other group, whatever the issue might be. Point is that at this moment during a pregnancy in the hospital, a pregnant woman exists as a pregnant woman, with the baby just being an extension of the pregnant woman, and we have to do what's actually best for the mom. And in this case scenario with the placenta previa, the best thing to do for the mom is that she do a cesarean delivery, because with the placenta previa issue, since the placenta is giving you a preview in the opening, you're seeing the placenta. So if you try delivering through the vaginal canal, you might actually get the placenta out first and then the baby. And the problem with that would be that the placenta is in such a bad position now, she's gonna have excessive bleeding and she's gonna die, right? She's gonna end up dying. So this is all about the mom here in this case as well. So if you get another ethics question where you have a different scenario similar to this, and doing procedure A would save the baby, while doing procedure B would kill the baby, but both procedures can kill the mom, you wouldn't do either of those procedures, because it's not about saving the baby, it's about making sure the mom is okay, right? If the mom lives, she can live to give birth again another day. The baby dying would be an unfortunate thing if it's going to happen, but it's going to happen depending on whatever the case scenario is, okay? So definitely a good point to bring up, and always remember that after a baby is born, right, and we have to do everything we can to make sure we always rescue young kids, right? No matter what, even if the parent says, no, let my child die, no, your child is a living being, and I'm going to make sure I save this child no matter what, whatever the reason might be. Even if, like we saw yesterday, even if the baby is born to a Jehovah's Witness, and theoretically the baby is now also a Jehovah's Witness and cannot take blood transfusions, but if the only way to save this young child is to do the blood transfusion, I'm going to do it, right? Doesn't matter. Faith is no longer a thing that you can use to kill a child, right? This is not something that happens in America, so you can't do that in America. So very important thing to watch out for. Good point. Next question here. 12-year-old girl is brought to the clinic by her parents for evaluation of decreased exercise tolerance and increased lethargy. Her parents say she becomes short of breath with minimal exertion, and for the past 2 weeks her gums have bled when she brushes her teeth. Okay. Temperature is fine, blood pressure and pulse are normal. Physical exam demonstrates pallor and hepatosplenomegaly. Lab results show hemoglobin is 6.8, so she's got some anemia. She's got a lot of blast cells. An extensive workup indicates that she has acute lymphoblastic leukemia, and the parents are informed that she will need chemotherapy. The parents do not consent to the treatment plan because they believe the side effects will be too severe and their child's quality of life will be poor. Despite an ethics consultation and a lengthy discussion about the benefits of treatment and likely consequences if therapy is withheld, the parents insist on taking her home without scheduling follow-up treatment. Next appropriate step in management, as I said, I have to save your child, no matter what. I always have to save your child. So obtain a court order for chemotherapy. Other answer choices that were wrong that some people chose were comply with the parents' wishes or proceed with chemotherapy immediately. You don't necessarily need to do the chemotherapy immediately because it's not something that needs to be done immediately, right? So that's what they explain here, right? Although parents generally have the right to make medical decisions for their minor children, parents cannot refuse life-saving treatment for a child. Treatment of ALL currently offers a survival rate of over 80%. So when the mom is arguing or the parents are arguing that her child's quality of life will be poor, well, the child will not have a life to have any quality to if we don't even do this treatment. The chemotherapy is a must here, especially because the chemotherapy is shown to improve survival rate, right? Without treatment, ALL will inevitably lead to death. Complying with parental wishes is not in the best interest of this child, who is your patient. Your client is the child, not the mom and dad, right? And if a child is your client, you're basically their number one defense, and you would have to do everything that's best for the child here, right? So this is when you do everything that's the best for the child, when the child is already born and breathing and has a name and all these things, okay? So at that point, you have to do whatever, even if the parents are practically saying let the child die, all right? If a delay for consent is life-threatening, emergency treatment for the child is legally authorized regardless of parents' wishes. However, this is not an emergency situation. So choosing proceed with chemotherapy immediately was the wrong answer choice there. It was a trick answer, but it was definitely a wrong answer choice because you don't need to do it immediately. So you would tell them, okay, listen, man, we got to get a court order now. You guys can go home, sure, but we're getting a court order to start treatment and chemotherapy for the baby now, for this 12-year-old girl now, because she needs it and it'll save her life, all right? Next thing here, 48-year-old man with extensive smoking history is evaluated for cough and an episode of hemoptysis. After the patient ignored his symptoms for weeks, his wife finally convinced him to make an appointment. Chest x-ray reveals a mass lesion in the right upper lobe. A chest CT scan and bronchoscopy with biopsy are scheduled for that afternoon, and the patient is instructed to schedule a follow-up visit with the physician 3 days later to discuss the results. The patient agrees to have the test done, but declines the follow-up appointment, saying that he and his wife are leaving for a previously scheduled week-long anniversary celebration the next day. Despite education about whatever diagnostic possibilities are there, he is convinced that his symptoms are stress-related and that he will feel better by the time he returns. The physician is highly concerned that the workup may show lung cancer, although the patient appears clinically stable. What is the most appropriate response by the physician? See, now this is a very realistic life scenario here. This can happen. This can definitely happen. The correct answer here, which half the people chose, 50%, please set up an appointment as soon as you return so we can discuss your results. And then let the guy go have his vacation. 25% of people chose, I recommend that you postpone your trip because there is a high probability that this is cancer. Why am I going to ruin this guy's life right now? I'm not going to lie. There's going to be a lot of people out there that will still truly think this is the thing to do, the wrong answer choice, right? There are a lot of doctors out there that today probably also feel like that wrong answer choice is what they should do. And this is why these ethics questions are so critical, right? It would be really messed up for you to do that. First of all, this patient is clearly very much of capacity, right? He has mental capacity. He's fine. He knows what's happening. You did the education. You gave him the diagnostic possibilities. So you already told him it might be cancer. You told him what's wrong with him. You told him everything he needs to know. He doesn't care. He's fine. He's feeling good. He wants to go on his vacation. He's excited. It's all good. It's good enough that he agreed to have the test done. That's all I care about as a physician. As a physician, I need to make sure he gets the test done, whether it be a screening test or whatever is happening, right? Once I have the test results, I can do my job. So if he's out there having his vacation, that's perfectly fine. And if I get the test results and I find out he has lung cancer, I will tell him as soon as necessary. So if it's not end-stage lung cancer where he can die during the vacation, I'm going to let him have his vacation. He'll finish. He'll come back. He already told me when he's going to come back, right? He's going for a week. When he comes back in a week, I'll call him. I'm like, hey, man, we got your test results. When is a good day for you to come in? Right? We'll get him an appointment. We will not tell him over the phone. That's another thing to very, very important to watch out for, right? So this is why we have these things here, right? The SPIKES protocol for delivering serious news and the counseling patients in clinical uncertainty, right? One of the key words here being establishing rapport, right? You really want to make sure you have a good connection with your patient, right? A connection of compassion, a connection of understanding, of even some level of affection, right? You have to know how your patient is feeling and respect that, right? You also have to understand your patient's family values, your patient's religious values, everything that's happening there. Being a doctor is much more than just taking care of a patient's needs, right? And that's because some of these needs are much more than just giving them a medication. So yeah, definitely want to make sure that you tell the patient to come in, right? It's a thing, it happens, and you know, whatever it is, this scenario is very, very real, very, very real. Okay, so watch out for that, and make sure you spend some time looking at the SPIKES protocol for serious news, as well as counseling patients in clinical uncertainty. These things are very, very realistic, and this is exactly how you're going to carry this out. All right, so that takes care of half of these questions. Let's keep going. Let's wrap up the rest of this, and then we'll be done with this video, and we'll be done with ethics. Alright, so here we go. 37-year-old man is brought to the emergency department after his brother called the police to report aggressive and disruptive behavior. The patient is worried that, the brother is worried that the patient took something that caused him to become violent. The patient appears intoxicated on arrival and attempts to punch several staff members. He is given intramuscular lorazepam and is admitted to the hospital under involuntary status. Temperature, blood pressure, pulse. His pulse is super high. Other than that, he's not doing so bad. Physical exam shows a 4-centimeter laceration on the left forearm with no active bleeding. An hour after admission, the surgical resident examines the patient and recommends wound irrigation and closure. The patient refuses the procedure and says, "I need to sleep. You can come back when I wake up." What is the best next step in management of this patient? Well, at this point, an hour after admission, the only reason you would even be seeing the patient and recommending something to the patient is because he's probably got mental capacity. This question looks like a question of capacity. Remember in earlier videos we talked about the difference between capacity and competence. Competence is all about whether or not you're of age, right? Are you an adult? So that's a whole different thing. Of course, this is an adult. He's 37. Capacity is whether or not you have decision-making capacity. Are you in the right mind to make the right decision? And he looks okay. Right, he's able to answer that he needs to sleep, he doesn't want to be awake right now, and that he can get the treatment as soon as he wakes up. That's fine, right? Because all we're doing here is wound irrigation and closure, and this is a wound from a stab that happened on his forearm, 4-centimeter laceration on the forearm, with no active bleeding. So that means that it's probably not going to lead to something very, very intense. He's going to be okay, right? So we can definitely go ahead and say that we're going to listen to him, right? Do not perform the procedure and reassess the patient after he awakens. 30% of people chose various answer choices that basically said perform the procedure, either because the patient lacks capacity to refuse due to drug effects, due to imminent harm, or given the involuntary admission status. But none of those are ever reasons to go ahead and proceed with the procedure in this scenario. First of all, really look at what's happened to him, right? He has a 4 centimeter laceration on the left forearm with no active bleeding. So 4 centimeters, not that it's 4 centimeters deep, but the length of the actual cut is 4 centimeters, and it's not bleeding. So he's not going to bleed to death. There's probably no infection for the most part. And whatever infection there might be is not going to kill him in the time he's sleeping, nor will it significantly worsen in the time he's sleeping for a little bit. So if this was my morning round and he told me this, I would come back later in the evening round and do it there. Pretty easy. So none of these are reasons to perform the procedure. Now, this, if he had drug effect, let's say he's still intoxicated in the drug, that is definitely not a time where I'm going to go ahead and do wound irrigation and closure. He's intoxicated, right? Imminent harm, there is none. As far as we can see, there's no imminent harm here. Or given the involuntary admission status. Well, involuntary admission status doesn't mean I can do whatever I want with the patient. He still has his own decision-making capacity, and he's going to do that when he can. Right, so that's basically all that happened here. Although this patient was admitted under involuntary status due to intoxication and aggressive behavior, it cannot be assumed that he lacks capacity to consent to or refuse non-emergency medical treatment. The informed consent process must be conducted for all patients, including patients admitted involuntarily for substance abuse or mental illness. This also goes for any other patient who might be a criminal, whatever might be the case. It doesn't matter. You treat everybody the same way. All right. And if it's very clear that they don't have mental capacity to make a decision, then you can go ahead and proceed with things if necessary. And here, there was no imminent harm. There's no need to do wound irrigation and closure ASAP. So we can wait it out. All right. So many things to watch out for in such a question. 30-year-old preemie-gravid woman at 10 weeks gestation comes to the office for an initial prenatal visit. She has no chronic medical conditions, no prior surgeries. While discussing what to expect during pregnancy and delivery, she states that she would like a primary cesarean delivery performed. So she's saying she wants a cesarean delivery, which is pretty rare. Most people don't want a cesarean delivery. Her mother has struggled for years with urinary and fecal incontinence after having 3 vaginal deliveries, and the patient does not want the same complications. So normally when a patient says they want something, the immediate thing, as we talked about earlier, is to just say why, right? She's explaining why. It's because she's seen what happened to her mom, who had 3 vaginal deliveries. Now she has fecal and urinary incontinence, which is definitely a real thing that can happen after too many deliveries. The provider discusses the complications associated with cesarean delivery, including the increased risk of complications in future deliveries. Based on the lack of medical and obstetric indications, the provider is uncomfortable agreeing to perform the procedure. Now remember, you're not obligated to take a patient. However, the patient states that she understands the risk and still wants a cesarean delivery. Hey, that's great. You can go get your cesarean delivery, but I'm not going to be the one to do it. And that's it. Right? Because I don't feel comfortable. Very easy, right? What is the most appropriate management of this patient? Refer the patient to another obstetric provider. 40% of people chose perform a cesarean delivery on maternal request. That is what you're going to do, but you're just not going to perform it yourself. You're going to have someone else perform it, right? Because you definitely cannot perform vaginal delivery on her. That's not going to happen. But if I personally don't feel like I want to do the cesarean delivery, I don't have to. And I'll have someone else do it. I'll refer her to another physician. Very, very easy question. But as you can see, people are divided, right? Half and half. So it's very important to understand certain things to make it an easy question. If you don't understand these little intricate things, it becomes a very hard question, as it was for some of these people here. Right? So it's perfectly fine. You're not obligated to do everything a patient needs, especially if you're uncomfortable. The provider is uncomfortable. Right? You matter a lot, just as much as your patient does. There's no imbalance here, right? So yeah, if you don't feel comfortable, then refer her to another physician. Very easy. Right? So here are 2 different things that are also going to be relevant to some of these other questions we have. Management of patients leaving against medical advice, right? AMA, very big deal. Oftentimes you might give patients medical advice and they'll be like, hey man, I get it, but I don't want this shit, I'm out. And then they leave. After that, if they get really sick or worse, and then they end up back in the hospital, they can end up saying you didn't advise me correctly, and then you end up getting a malpractice suit or something, and it sucks, right? So you have to document it, right? So first thing is assessing the decision-making capacity, which is done like this, right? Can he communicate a choice? Does he understand the information you provided? Does he appreciate what the consequences of the information you provided is? And does he give rationale for the decision he's making? Why don't you want treatment? Just because you're stupid? Just because you're poor? What is it? Something must be there. You don't believe in treatment, whatever the reason is, as long as he gives a reason, right? And if he has all of that, then you provide options for continued care. And one of the things you have to do is have him sign an AMA. He has to sign that he was given medical advice and he was told that what he is doing is against medical advice. This is why it's called signing an AMA. And then he can go home, at which point now you're safe from him ever coming back and be like, oh yeah, my doctor didn't tell me I was going to get a heart attack if I didn't treat myself, because you did. All right, so that's what's happening there. Right here, 36-year-old man comes to the emergency department complaining of 2 days of fever, headache, and vomiting. He has no other medical problems and takes no medications. Does not use tobacco, alcohol, or drugs. Lives with his wife and 2 school-aged kids. Temperature is super high, 104. Blood pressure is low. Pulse is 100. That's very high. Respiratory rate is 16. Physical exam shows petechiae and purpura on his trunk and lower extremities. He is unable to bend his neck to touch his chest. All right. Examination of CSF is consistent with meningococcal meningitis, which is why he can't bend his neck. He is informed of his diagnosis. He is told management will consist of hospitalization, antibiotic treatment, and isolation precautions. However, he refuses hospital admission and insists on being treated at home. This is not something you can treat at home. He is alert and oriented and appears to understand the risk he poses to himself and others by refusing hospitalization. He also declines requests to involve his wife in the decision-making process. What is the best next step? Okay, sure. His wife doesn't need to be in the decision-making process, not in the decision-making process. But this is one of those diseases that are in the list of reportable things, basically. You would have to hospitalize and isolate the patient against his wishes. Why? Because he poses a threat to other people. Meningitis is a huge issue, and if he goes home, he can essentially kill his 2 school-age kids and possibly kill his wife too, because meningitis can become fatal. And this is really bad. 20% of people still chose respect his decision and arrange for home antibiotic therapy. That won't work, because the antibiotics you take in this case scenario are usually not something you can just take at home. Also, because we can't monitor the effectiveness of the antibiotic if he goes home with it. Right? So that means that he might go home and not take the antibiotic, and then he's going to kill people with meningitis. Right? So this patient presents with meningococcal meningitis, a highly contagious disease that can lead to devastating complications and outbreaks in an entire community. Treatment involves isolation, IV antibiotics that he cannot take at home, and supportive care in an intensive care setting to monitor disease progression. We have to also be able to see if we did kill the meningitis. A patient who does not comply voluntarily needs to be hospitalized against their wishes. It is ethical for the physician to isolate a non-compliant patient until the patient no longer poses a risk. This patient should be placed in an isolation room with droplet precaution until all his contacts receive prophylactic penicillin. His wife and kids have already been exposed to the disease and all need prophylactic rifampin. Rifampin, right? Because it's the rifampin rifle from Sketchy Micro. Rifampin or ciprofloxacin. Protection of individual patient rights, which is autonomy, must be balanced with the physician's duty to protect the health of the public, mandating hospitalization and isolation of patients with a communicable disease. So, although his wife doesn't have to be part of the decision-making process, this cannot be kept confidential from her wife, though. So her wife and kids would find out that their father has meningitis, which isn't really that stigmatizing. It's not like he has herpes or HIV. And then they would have to be given the rifampin prophylaxis so that they don't develop really bad meningitis as well. Okay. It's very important to know where you're supposed to hospitalize a patient against their wishes. Doing things for a patient against their wishes is the thing. As I said, you and your patient are pretty equal. There is no, like in New York and in America in general, the tenant has many more rights than the person who's actually owning the house. That is not a thing in medicine. You as a physician and your patient both pretty much have the same number of rights. Okay, so very important to make sure you never think that the patient is above you or that you're above the patient. A 34-year-old man calls the office requesting an urgent appointment due to cough and cold symptoms pre-COVID, right? So this is happening in like early 2018 or something. His temperature is 99F, but he feels miserable and is unsure if he should go to work the next day. He has a history of seasonal allergies and knee pain from a past sports injury. No other medical problems, but does have a history of frequent office visits. The receptionist informs him that the physician is preparing to leave as it is near closing time, but that an appointment is available for the next morning. He declines the offer of an appointment and hangs up. As the physician leaves the office 30 minutes later to make evening rounds at the hospital, right? So he's leaving the clinic now, leaves the office. Yeah, the patient arrives and insists on being seen immediately. Right. So this is the whole being seen after hours concept. He sounds congested and coughs occasionally, but is breathing normally. No other symptoms. He again asks to be examined. What is the most appropriate response? Although I understand your concern, we should address it tomorrow because it is not an emergency. Right? This was choice A, and 60% of people picked it. Choice D was, and 12% of people picked it, I insist that you go to the nearest emergency department for evaluation. And we just said never choose this answer choice if it's not actually an emergency. He's not dying, right? Nor is he going to die from something like this. 10% of people chose choice E, which is let me take a quick look. It's probably nothing to worry about. That would be unethical too, right? Now, of course, in the real world, in your own real practice, it might be something you'll do, and it's up to you. But as far as this exam is concerned, it is not something you can do, right? So you cannot pick that answer choice. Okay, it's not okay to do that, because it would be unfair to other people that might have wanted to see you after closing time and couldn't. Right? There might have been other people that called your office and wanted to be seen, and your secretary or receptionist told those patients, "Oh no, we close at 5. You can't come." So then, if they can't come, neither can he. That's it. So be professional. Let him know to come back tomorrow. If he starts acting all ballistic and animalistic and all that shit, that's beyond you, and you just move on and go to the hospital and do your rounds. That's it, right? So that's on him if he's gonna act stupid. Very important to watch out for that. Now, this reinforcing is very common in many communities. And what is this reinforcing? So very important to talk about this because I've personally seen this thing in brown communities here in New York. So they see communities of Indian, Bengali, and Pakistani hospitals in New York City. So let's take a look at what's happening here. Performing an exam after hours is inappropriate and reinforces the patient's sense of entitlement and poor boundaries. Right? You got to establish your boundaries, man. You're a doctor, you're a businessman, these are your clients, and you don't meet with clients after your office hours. End of discussion. Right? This reinforcing is very common in many communities. The most appropriate response is to calmly set limits and establish clear professional boundaries. These boundaries have mostly vanished in most of these DC communities I worked in, where doctors are unprofessionally eliminating boundaries between them and the patient because of cultural things, where the patient in the mixture of our cultures, the patient might actually praise the doctor like a god, and then as a god you have to do what the patient is asking. Something like that is the mentality they go by, and it's really messed up, right? Because sure, you praise me and that's great, but that doesn't mean I have to listen to you, right? No, it doesn't even work like that in a religion where you praise any god. It doesn't mean that the god has to listen to you. You hope he will, and he might, but that's about it, right? So very important to make sure that that mentality isn't there, right? If you get rid of these professional boundaries with your patients, then the unprofessional aspect of a patient sitting there looking at you and telling you, hey, I need X, Y, and Z, do it for me, is not that far, right? Then the patient's going to sit there and tell you, I also need these antibiotics, I need opioids, I need a whole bunch of aspirin, and it might not even be for him. He might not have any of these symptoms, and he might need it for like another friend or something, right? Or maybe he sells it. So it's very important to never prescribe things to patients who don't need it, right? Because if I prescribe aspirin to a guy who has no need for aspirin, he's probably just getting it every month from his insurance company just so he could sell it for like a good couple bucks, and then use those couple bucks for something else like buying drugs, right? Who knows? It's very important to set these professional boundaries. These questions mean a lot more than what you're seeing here. Last two things. So this next one, 24-year-old bicycle courier is brought to the emergency department after he was struck by a car. He was thrown about 20 feet through the air and was initially unconscious when other eyewitnesses reached him. On arrival, blood pressure is very low, pulse is 130, respiratory rate is 28, oxygen saturation is only 88%. He appears extremely anxious and in respiratory distress. When he sees the trauma team preparing supplies for intubation, he says no tube. However, soon after, he loses consciousness while resuscitative efforts and trauma survey exam are ongoing. What is the most appropriate course of action? Okay, so he's freaking out, right? He saw the tube. He's also freaking out because he just got thrown 20 feet through the air. He thinks he's gonna die, and you're gonna need to intubate him, but he just said this no tube thing and knocked out. That no tube does not count as refusing treatment. It also doesn't count as a documentable DNR, right? So you intubate the patient without obtaining consent because this is life-saving treatment, right? 10% chose do not intubate the patient and document his verbal refusal, and then 10% chose proceed with intubation and obtain retroactive consent after he recovers, which is a very tricky asshole answer choice. There's no such thing as retroactive consent. You can't do something and then go ask for consent after doing something. That's not how that works, right? Imagine if retroactive consent was a thing, that you could rape somebody and then ask them for consent and see if they're going to say okay. Like, that's just not a thing, right? So that answer choice that 10% of people chose, they must have been pretty fatigued or something, and they really didn't see how retroactive consent, although it sounds very interesting when you call it retroactive consent is basically saying asking for permission after committing a crime. It's a crime already, right? So there's no permission after doing something. You don't ask for permission after doing something, you ask before doing something. So that answer choice, the second wrong answer choice, retroactive consent, was just completely wrong. Do not intubate the patient and document his verbal refusal. I can see where some people might have thought that was okay. A major exception, though, to informed consent is when a life-saving procedure is necessary in an emergency and obtaining consent is not possible. You see, this is not informed consent, right? When he said no, not tube, this is also not informed refusal. He's not informed. He doesn't know everything that's happening to him, all his alternatives, what's going to happen if he doesn't get the intubation, how the intubation is going to be done, right? All the things of brain mnemonic for everything that he needs to know about the informed aspect of informed consent. So since he doesn't know everything that's going on for him, nor can you ask him, are you sure that you do not want to be intubated? If you could ask him, are you sure you do not want to be intubated? And he says, no matter what you do, please do not intubate me. Then you would not intubate him, even if he will die, because that counts as documenting refusal. All right, but you can't ask him anything. He lost consciousness while resuscitative efforts were going on. A final consideration in this case is that due to emotional and or physiological derangements resulting from trauma and or hypovolemic shock, this patient may have temporarily lacked decision-making capacity, right? You can also think that he's just too scared. Like I said, he's just freaking out. Right? A person that is having a panic attack essentially is not in the right mental capacity. So he can't theoretically give informed refusal or consent. So you go ahead and do the intubation. Right? So these are all great questions to keep in mind when you see another question that might parallel some of these scenarios. Last ethics question for today, and then we're done with ethics. It says a fourth-year medical student working in the ICU is helping to care for a 75-year-old with end-stage lung cancer, right? Lovely question. This is actually a very real thing as well. It's also in the book, and we talked about it earlier. The patient suffers a cardiac arrest and, despite intensive resuscitation and emergency management, cannot recover and is declared dead 15 minutes later. Team members provide emotional support to his family, which is a very real thing. You have to do this, right? So I've done it as a student as well in one of my rotations, where a patient died, they had lung cancer, they couldn't make it, and as a team, we all went to meet the family to let them know what happened, hear them out, be compassionate, and that compassion doesn't include anything weird like giving hugs or something like that, because we just don't have that connection, right? But it did include, apologizing, understanding what they're saying, hearing them out. Depending on the connection you have with the patient, like, how long you've known him for and stuff, you might even want to shed a tear with the family. Other than that, that's about it, right? But that's a very real thing. So I definitely wanted to stop there and tell you this is a very real thing. Team members provide emotional support to his family. The supervising physician reviews the details of the patient's management with the student. the physician is aware of the student's interest in critical care and asks if she would like to practice performing procedures, including a pericardiocentesis and intubation, on the dead patient, right? What is the most appropriate action by the student? Well, first of all, almost any time an attending physician asks you to do something, it's going to be safe. Like, it's very rare instances where a physician, an attending, is going to ask you, hey, do you want to do this or can you do this? That should you say no. One of the most notorious case scenarios where an attending might ask you to do something and you definitely say no is asking somebody for informed consent. Okay, an attending might look at you and be like, hey, Amir, can you go ask Mr. X for informed consent on this procedure? Now, if I don't know the procedure inside and out, I can't do it, right? And I've had to say no even here right now as a clinical research coordinator, because there are many times new pharmaceutical companies send, I work in the head, neck, and thoracic department, right? So I work with lung cancer patients mostly, and new medications come out to treat lung cancer, and maybe a patient wants to sign up for a certain medication, but the doctor is busy. So if he tells me, Amir, just go get the consent, I can't just go get the consent. I can't, because I wouldn't know how that lung cancer works, everything about the medication, the ins and outs of the medication, all the side effects, etc. I can't do it, right? So at that point, what I usually have to do in my personal scenario is that I just wait until the doctor's free, right? So when he comes later and tells me, hey, did you get the informed consent? I'm going to tell him, no, I didn't get the informed consent because I didn't feel comfortable doing it. But the patient is coming back tomorrow, so we can do it tomorrow, right? Or whatever works best, right? And that's it. So it's very important that that is one scenario where you basically would have a attending that can tell you to do something and it was wrong of them. Here, there's nothing, right? So this is actually okay, but I could see how someone might think it's fucked up to practice things on this patient that just died. However, the correct answer here was perform the procedure only if permission of the family is obtained, okay? Well, 40% of people chose do not perform the procedures because they are unethical. Well, remember that almost every procedure we've performed in med school in the early years, like invasive procedures, were on dead patients. They were cadavers, and those cadavers were dead patients who either gave permission themselves or their family gave permission for their body to be used in medicine and medical practice. The ethical dilemma of using newly deceased patients for training involves weighing the conflicting considerations of respect for patient integrity with the need to train healthcare providers to perform life-saving procedures. If we don't, imagine a world where we can never use dead bodies for training purposes. Then how would you train healthcare providers? Because you can't train healthcare providers with real patients who are alive. You can't mess up on them, right? And then that's going to lead to lawsuits and they can die and shit. So it's definitely a thing that you do need dead bodies to do medical practice on. The consensus of major medical organizations is that it is ethical for students to perform procedures for training purposes as long as the physician obtains permission from the family or the patient himself prior to death before the student performs the procedure. Also, make sure you remember this part because this could be another question. The training must occur as part of a structured training sequence and be performed under close supervision. It's not that you can just go hack away at the dead body. It is not unethical if permission was provided. Simple. All right? So very important to keep this in mind because you can see how this was also pretty much half and half of people. 40% chose the wrong answer choice. All right? So this topic is also very lightly, it's like one sentence, but it is discussed in First ICK, and we talked about it in one of the earlier videos in ethics. So those are all the practice questions. In the next video, we'll move on to gastrointestinal manifestations. Thanks a lot for joining, guys. Keep working hard, and I'll see you guys again later.